This slide is called Shift from Institutions to Home Care, but I should draw your attention to the fact that there's another shift here as well. Up till now, we've been talking about reverse mortgages. This is obviously not for people on Medicaid. So as I mentioned, a home mortgage is actually a bad idea for someone on Medicaid. The home mortgage is a way for someone who has assets to finance the care in his home himself. Now we're switching to another topic, which is home-based care funded by Medicaid. So we're looking at a different group of people who do not have the money to pay for their own care. And historically, well, let me go back a bit. This slide summarizes in part the reading in the short extract called Preparing to Age in Place, the Role of Medicaid Waivers in Elder Abuse Prevention. That's by Skar and Zural, and it's on the website Blackboard. And as this slide states, Medicaid originally only provided nursing care, that is, help with activities of daily living like bathing, eating, and toileting in nursing homes. And then there were a couple of groundbreaking changes. In 1981, the Omnibus Reconciliation Act created Medicaid waivers. Side note on waivers. The Center for Medicare and Medicaid Services allows states to try out different ideas or approaches for providing care by waiving certain requirements of the Medicaid program in limited cases. So requirements such that the state must have equal programs for the physically disabled and the mentally disabled. So if the state wants to try out a new idea for the mentally disabled that's not available to the physically disabled, it would have to get a waiver. It would rely on a waiver from the federal government for which it would apply. And these waivers allow for variation and innovation. So the new waiver in 1981 allowed for nursing services in the home. The state could use managed care, which is something like an HMO, to deliver the services. So just the possibility of care in the home only became available in 1981. Then in 1990, Congress enacted the Americans with Disabilities Act to protect disabled individuals from discrimination. And I hope you're thinking, gee, some of these elderly people who are bedbound are disabled. And in 1999, the US Supreme Court decided the famous Olmstead case, holding that unnecessarily segregating disabled individuals in institutions is illegal discrimination. So that meant that Medicaid had to provide some home-based services. They couldn't rely on institutionalizing people. So Medicaid and the home and community-based service programs are important for complying with the Americans with Disabilities Act and with the Olmstead ruling. This slide has a lot to say for itself, so I don't feel I have to elaborate too much. It's explaining this term, managed long-term services and supports. That's an umbrella term that covers both nursing homes and community-based services. I wish I could make it more concrete for you. It's a delivery system, at least in New Jersey, a delivery system for managed care that is an arrangement between the state Medicaid on the one hand and managed care organizations, or MCOs, on the other. So MCOs do what an HMO does for your employer-based health insurance program. It provides the whole range of services and the billing and all of those services for a certain fee, which in this case the fee goes to the state. New Jersey, to make it even more concrete, has 5 managed care organizations. They are listed here. They're well-known healthcare organizations. The MCO might supply both the home and community-based care and regular medical care, primary and acute care. And incidentally, in New Jersey, regular Medicaid patients are also enrolled in a managed care organization. So the fact that you have an MCO as the intermediary between Medicaid and the patients isn't unique to people in long-term care. It occurred to me that you might be getting confused about Medicaid because we see that it popping up all over the place. And in New Jersey, it's even more confusing because here it's called NJ Family Care. In fact, many states don't call it Medicaid. I wonder if that's partly what makes people hostile to Medicaid, that they don't think that the New Jersey family care they get is a form of Medicaid. So it's a huge program. Up till now, when I've talked about Medicaid, it's been health care for the aged, blind, and disabled. So that's the red door, second from the left. Now we're looking at Medicaid managed long-term services and support, which is the other red door. And this one requires Medicaid financial eligibility plus the need for help with activities of daily living. So that's eating, bathing, toileting, and so on. So it's a separate program underneath the same umbrella, the same Medicaid umbrella. We haven't looked at plain Medicaid, the blue door on the left. That's Medicaid for poor families, which is what most people think about first when Medicaid is mentioned. And as for the other sub-programs, I don't need to go into those, and so I won't. Okay, here's something that should be obvious by now. The basic requirements for Medicaid long-term services and support, or managed long-term services and support, are the same as Medicaid generally on the financial side and the age side. You have to be over 65 and you have no money. But unlike what we saw in the case of nursing homes, you can keep your maximum $2,313 and keep your home to cover your living expenses. It wouldn't do any good to leave you in the community without a house or without an income. Then there is also, besides the financial need requirement, there is the medical need requirement, and that is that you have a nursing home level of care, that is, assistance with at least three activities of daily living. This might be our first encounter with ADLs, or activities of daily living. Strictly speaking, help with bathing and dressing is not medical care, but that's exactly what disabled people or people with dementia might need. So ADLs are the key to Medicaid long-term care. Someone who cannot feed herself or move from the bed to a wheelchair needs help, but without a third ADL, she won't be able to get it from Medicaid. You need 3 ADLs. This is just of general interest. The portion of the Sklar and Sura article that I asked you to read states that cost savings is a big motivator of home and community-based long-term care services. And you can see in this chart that the percentage of Medicaid spending on home and community-based services as opposed to institutional services grew rapidly from 1995 to 2010, then stayed roughly steady, with home and community-based services now taking up 57% of the long-term care budget, as compared to 43% of the budget going to institutional care. Okay, the key to home and community-based services is that they are delivered in the home. And they include most of the help that a person would need. So not just the activities of daily living, but help with the household and meals and modifications to the house and transport to doctor's appointments and so on. So keep in mind that there is a lot going on. There's help of a very personal kind with potentially lots of caregivers to be coordinated, and that sets us up for the next slide. Maybe everything that I've been describing sounds like a lot of spaghetti to you. Isn't the Medicaid recipient going to find herself at the mercy of the managed care organization and being assigned a package that's convenient to the MCO? And they'll say, that's just the way we do things, etc., etc. Well, that was answered in theory anyway by the Center for Medicaid and Medicare Services in 2014 when it amended Medicare waiver regulations. Regulations, catch that? A word that gladdens our hearts as lawyers. It's a tool or a weapon that we can use to help our clients. So the CMS amended the regulations to include person-centered planning requirements and written service plan requirements. Now, person-centered planning, or PCP, requires the managed care organization to take its direction from the Medicaid recipient or his or her legal representative. That is, the MCO has to tailor the care to the goals, wants, needs, and strengths of the individual. So what are the legal rights here that we can use to advocate for our clients who are not satisfied with their managed care organization? First of all, the consumer has a right to participate in drawing up a care plan. He or she has a right to a written plan. And finally, family and friends cannot be made to do some of the work that the MCO should be doing. If they help, it's strictly voluntary. So we'll see how robust those guarantees are on the next slides. I'm sorry about the very full slide, but these regulations make me happy. So what do they mean? Number one, the individual, well, start with the beginning. The individual will lead the person-centered planning process where possible. The person-centered process ... Number one includes people chosen by the individual. And number three is timely and occurs at times and locations of convenience to the individual. So that means that the person, the patient, can control where, when, and who shall attend the care planning meetings. So for instance, can insist that they take place in the individual's own home, can insist that they be at a time of day that's convenient, like the morning, that they can take place in the presence of an adult child or another person who will be helping the consumer, helping that person get to appointments or dealing with the fallout if an aide fails to show up, or the individual is entitled to exclude a family member for some reason, perhaps a child from whom the incapacitated person wants to keep a secret. Number two says that the managed care organization must provide necessary information and offer informed choices regarding the services and supports that are available. So, for example, the consumer must receive easily understood information about available services, supports, and providers, and the choices on offer must be informed, which means it's not enough to hand the consumer a booklet or point him to a website. Everything has to be explained and tailored and accessible. And then again, timeliness, the information must be provided in a timely manner, not at the last minute. The options can't be explained to the consumer for the very first time at the service planning meeting, leaving him or her no opportunity to review or to consider the options. You can't be railroaded into a one-size-fits-all plan, in other words. Okay, more detail, but such great detail. So too often service plans rely entirely on functional assessments and are just a recitation of the Medicaid-approved services that address the consumer's needs with respect to the ADLs like bathing, dressing, and meals. The new rules require the consideration of the consumer's strengths, preferences, goals, and desired outcomes. So they have to take into account what kind of accommodation the individual wants or doesn't want, and reflect the services that are available, that the individual can draw on. We'll look at that in the next slide. Reflect the risks and the measures in place to minimize disasters. So it has to be tailored to the individual's desires. So the individual can decide what kind of a life he or she wants to lead, or at least what degree of independence he or she is willing to give up for care of a specific sort. Okay, so the plan that's drawn up as a result of this person-centered planning must reflect the services that will be offered by the managed care organization, as well as the supports that are in place from the family. That is, services and supports, including natural supports. Natural supports are unpaid supports that are provided voluntarily to the individual in lieu of HCBS waiver services and supports. It turns out that Medicaid, via the managed care organizations, has often authorized service levels or determined how many services an individual requires, with a presumption that families should be providing a certain level of personal care assistance. And due to that presumption, these managed care organizations have offered reduced services to the individual. And then that has the knock-on effect: by offering the reduced services, the family members are compelled to provide assistance to cover the gap. So states like Florida and 12 other states state that Medicaid provides only services that are medically necessary, and that has been interpreted to mean not for the convenience of the family members, even where the convenience in question was being able to hold down a job, or as the agency put it, quote, to work on the schedule of the job you have chosen, unquote, as though, that's just a whim or a luxury to go to work. Advocates for Medicaid beneficiaries have persuaded Florida to at least respect a caregiver's outside employment. And on this slide, you see the regulation, the one I just read out to you, that elder law advocates are using to contest the Florida rulings, the rulings in the Florida courts in favor of MCOs that offer only reduced care because a family member was deemed to be available to help. And the advocates had some great cases. In one, the patient's supposedly available caregiver was his 78-year-old mother. In another case, a woman's husband was the available caregiver, although he was also in his 70s, suffered from Parkinson's disease, and had suffered 2 strokes within 8 months of the administrative hearing. So these were cases in which it was clear that caregiving was a real hardship, or even impossible, to the family members who were deemed to be available. So Florida Legal Services contested those decisions and obtained a change in Medicaid policy in Florida to establish that a family caregiver may not be presumed to be available during that caregiver's hours of employment. So that's a limited victory, but it is a victory. The problem still persists in many states. Probably it also persists in Florida among people who don't know that they have the right to protest. As an advocate, you should insist that natural supports should be factored into the service authorizations only to the extent that those supports are voluntary. The plan cannot be drawn up in such a way that family members are forced to provide some of the care. We have to discuss 2 more programs under the heading of home and community-based services. For Medicaid recipients, there is another program that gives them more control, which is cash and counseling. And that's more or less what it says on the tin, as the Brits say. The states give you cash to purchase services for yourself. Some programs provide participants with cash directly, and others use a financial management company or fiscal intermediary that handles payments to carers. on the participant's behalf. But most importantly, besides being able to hire your own caregivers and services, you can hire whomever you want as your caregiver, including family members. So these might be people who are providing care anyway and have to take time off from work to do so. Now they can get paid for it. And a consultant from one of the managed care organizations develops a cash management plan with the services that the individual needs and provides the names of individuals and agencies that they can hire. So that's the most home and community based that's possible. Okay, a bit redundant. I think I said a lot of this earlier. So the funds from cash and counseling can be spent on personal assistance services. Again, underlined, participants can hire friends and family. Assistive technology, such as remote controls, special cooking equipment, etc., and for home modifications. So if it works, it sounds great. It does require a lot of self-direction. Okay, a bit redundant. I think I said a lot of this earlier. So the funds from cash and counseling can be spent on personal assistance services. Again, underlined, participants can hire friends and family. Assistive technology, such as remote controls, special cooking equipment, etc., and for home modifications. So if it works, it sounds great. It does require a lot of self-direction. Here's the last program, Jack. You may have wondered about those individuals who are not Medicaid eligible but can't afford personal care in the home. The Jersey Assistance for Community Caregiving provides some self-directed care for persons who don't qualify for Medicaid because they earn just a certain amount too much. A certain amount is right in the center of the slide. They have a monthly income of up to 365% of the federal poverty level, or $3,799 for an individual per month, as opposed to the $2,313. And their countable resources have to be at or below 40,000. They live in their own home or in the home of a relative or a friend, and there is a copay based on countable income on a sliding scale. So that is a bridge between the people who are very poor and the people who are poor and couldn't afford care on their own.